I don't know if having a visual or two is helpful, but I'll try to do my best to describe the slides. I don't want to just read the words, but I think I've recognized at least 5 or 6 or more of them all. I've seen his patients, and thanks for waiting on me here. So I thought I'd just give you some glaucoma basics. If you see me in the clinic, you've heard this before, but glaucoma is not just a disease, but it's a collection of diseases that what have in common is damage to the nerve, or a disease of the optic nerve. And we'll describe the anatomy here a little better in a few minutes, but think of the optic nerve as a cable collecting all the signals that come into your eye and will connect it to your brain. So if there's damage to that cable, it doesn't usually help vision be what we would like it to be. So it's not always associated with higher eye pressures, but it's most commonly associated with higher pressures because that's one of the best targets to treat. The problem with the cable of the optic nerve, just like other parts directly connected to the brain, like the spinal cord, is once they're damaged, you can't repair them. So as damage is occurring, most commonly it affects the peripheral vision first, but not just like a tunnel, more like shadowing a portion of the vision, and it's commonly going to affect the top half or the bottom half, one more than the other. It's a bad combination. You have both top and bottom half. It doesn't leave you with much, and then that's what's kind of commonly described as a tunnel vision, or looking through a keyhole or something like that. Was okay. There we go. Just keeps going forward, so you can try to go back. On the screen before, were you looking at this slide just a moment ago?
Yes.
Yes. Okay. Oh, here. I'm seeing 2 on the computer, but showing 1 here. So a quick review of the anatomy. The cornea is like the windshield part of the eye that is important for focus. You can't have too dry of a cornea. You can't have too scarred or cloudy of a cornea. You want your cornea clear, slick, smooth, like a crystal clear glass or crystal. And so focusing light, the target is going to be on the retina, where you'll conduct the vision signal toward the nerve. That's going to be connected to the brain, and then there's a fluid produced in the eye that's related to the pressure. The buildup of the fluid increases as outflow gets damaged. A lot of the target to treatment is going to be in reducing the amount of fluid that the eye is producing. And so visual here, the cornea and the pupil, this would be an eye that'd be wider than I can span, looking up. The fluid is produced by a muscle that suspends the lens, and that fluid comes around the front surface of the lens through the pupil and exits the drain tissue. It's in a ring around it on the end of the cornea into the white of the eye, the sclera. So focusing, we'll switch ahead here. Focusing light through the cornea, through the lens, onto the focusing point of the eye is what's needed for good vision. And then the nerve is going to take the signal. And so when we're talking about the optic nerve here in the future, we're talking about specifically the optic nerve head. That's the part of the eye that you can see from the front on exam. And we can't see any further in any of the nerve closer to the brain, further behind the eye, but it's going to run about 4 or 5 inches from the back of your eye to the brain. So, just another couple quick terms. The macula, you've heard of macular degeneration. The macula is the center focus part of the retina, required for detailed vision. And then there's these ganglion cells, which are the part of the retina cells specifically that feed into the nerve and create the optic disc. So specifically about pressure, we're talking about the aqueous, the clear liquid that the eye secretes slowly. It's produced in that structure right along the lens. It comes through the pupil and then exits in front of the iris through the trabecular meshwork. A lot of the drug targets are specifically the amount of aqueous that's produced. It's a lot. and how easily the drain tissue lets fluid through, so the resistance to outflow. And the drainage
Hey, Tim.
angle, you know, I was
Come on in,
describing
have a seat.
earlier there as where the iris and the cornea meet. So we're trying to help lower resistance right there. Open angle glaucoma is about 90% of cases. Being the most common, it looks the most normal. The eye's going to appear normal, but what becomes abnormal is the health of the nerve, generally as pressures are higher than what's healthy. It's the drain tissue just doesn't let fluid out as easily, but it would be so slow and gradual that it's sneaky. You just wouldn't know that you had a problem until it's very late in the condition, being slow and painless. As opposed to angle closure, that's something that you know you have a problem over the weekend, or within a few days. Pressure gets higher much quicker when already crowded drain tissue just becomes completely blocked. So with a rapid rise in pressure, it's very painful, like worse than a migraine. A lot of people will confuse it for a migraine because it can cause nausea, light sensitivity, but specifically reduced vision that does not improve while the pressure is so high. And that's the kind of medical emergency that the emergency department would call us for. So when the peripheral iris is blocking the drainage, the pressure gets high, pain, nerve damage, and then a visual here. Sorry, this is pretty blurry, but normal eye, this is normal half compared to, so close I can't see it very well, but peripheral iris, instead of being flat along the contour of the front of the lens, it gets bowed up and blocks the drain angle, which would otherwise normally be open angle, closed, and the closed angle here. So detection is what we're always trying to get a diagnosis as early as possible to keep the nerve as healthy as possible. And you just can't count on any symptoms in open angle glaucoma. So it takes regular eye exams to know if the nerve is staying healthy. And testing would include, but is not limited to, pressure measurements, the visual field test, which no one really enjoys taking because it requires concentration. It takes some vision to see that boring white bowl and the right lens in front of your eye so that that bowl that's 18 inches away is in focus. And then concentration and response to when a little dim light flashes up. Lots of people don't know if they see it. Normally you're going to see some, and normally you won't see some. It's going to really try to get right to the threshold of what is visible to you versus what is not visible, and then compare to normal. And I should have put some normal versus not normal visual field pictures in here, but I'm sorry I don't have those. But I've probably shown you your visual fields when you've taken one in the office. Oh, I'm sorry. Back to the testing here. So yeah, not just visual fields, but there's also imaging where we use a laser focused in the back of your eye at the optic nerve tissue to try to measure the amount of tissue, which we hope will stay the same. If glaucoma is controlled, the nerve stays the same. If glaucoma is uncontrolled, whether the pressure is too high or whether the nerve just isn't really tough enough or lasting long enough, the nerve tissue thins when ganglion cells are lost. And then just looking in the eye, looking at the nerve and trying to describe it and draw it and compare to previous descriptions of drawings is helpful. Not any one test is guaranteed to be a perfect monitoring. It really takes the accumulation of both the visual field and the imaging and to correlate that with the exam. If it's decided that the nerve is not staying the same, if it's not looking as healthy as we would like to be, or if the pressure is just abnormally high, usually the first line of treatment is eye drops. There's about 6 different classes of drops. There's a bunch of brands, a bunch of generics. There's really not many really good new drops that have come out in the last 20 years. I mean, we're using mostly the same medicines as before I started doing ophthalmology. Every once in a while something promising will come out, a new class or something, but there's really not been one that's as potent as we would like to be without side effects that people just don't like, whether redness or irritation, Allergies can pop up at any time. But prostaglandins are the variety of drops that we use most commonly because it's a once-a-day medicine. For most people, once a day is going to be a lot better to adhere to be compliant with. When we add a second bottle, second prescription, that's more than once a day, the chance that you can be perfect on your schedule, is cut in half. And then probably every other time that you have to use a drop, the compliance is going to reduce significantly. But unfortunately, commonly we have to add more than one class. So beta blockers are a common second class. It's a medicine commonly used for blood pressure. But there can be some side effects from beta blockers as far as lower blood pressure, which doesn't help perfusion into the eye, lower heart rate if you're prone to low heart rate. Beta blockers don't work as well when you're asleep or at night, so I'm always checking with people who are on those to make sure you use them in the morning, not before bedtime. Most commonly, prostaglandins are put in at bedtime so they don't make your eye look as red during the day if you put the drop in before you went to sleep. But if you keep collecting classes of drops because the eye pressure is harder and harder to control, there are other classes, most of which make the eye make less fluid. But a few of the newer ones are targeting the drain tissue and try to relax the drain tissue to help fluid exit the eye with a little less resistance and a little lower pressure with less resistance. But no drop lasts for more than a day, so if you did your drops yesterday, and you're doing them today also, they'll be working. If drops aren't working well enough or aren't able to be kept up with the schedule well enough, an alternate treatment can be the SLT laser, which is something that does not show any signs. If an SLT is done well, you can't tell that it's been done. You can't look at the drain tissue and see any physical holes, but it's putting energy on that mesh drain tissue to try to make the drain tissue relax or open up just a little bit, sort of like beating the dust out of a filter. It doesn't give you a new filter, but it makes your filter potentially work a little bit better. On average for about 2 years, so if it works really well, it can be repeated again, but the second treatment doesn't work quite as well as the first treatment, and it's rare to get to a third treatment without needing to do more. So it's important to realize if you've had a laser that's helping your eye pressure, don't think that you're cured as far as an SLT goes. That's different than a laser iridotomy that's done for the closed or crowded variety where the iris was bowed forward. I could have put a lot more pictures in here. I'm sorry I didn't. Sorry I didn't show every single thing that I'm talking about. But when the iris is bowed forward, if you make a small physical hole in the iris, you can allow it to flatten out, like if you were to put a hole in a sail. Instead of catching the fluid behind the iris as bowing it forward, a laser iridotomy for narrow angle or closed angle can help if the drain tissue is not permanently scarred. So if it's been recently crowded, the laser iridotomy can be potentially curative to keep the drain tissue open, but the drain tissue still has to do its job, which is the problem with the open angle that I was talking about. And those laser treatments that I'm talking about are not really surgeries. We're usually talking about in-office procedures. Down the road here, we do them through the surgery center, but it could just as easily be done, just walking around the corner from the exam room, clinic. And if those lasers work well, if the drain tissue is working better, if the drain tissue is less crowded, it may reduce the need for drops. But it just depends how well the drain tissue is functioning in the first place. When drops and laser are not adequately controlling the pressure or preventing the nerve from looking a little bit worse over time, unfortunately some people have to go to surgery. And there's a wide variety of surgeries that it's kind of like the more solutions you have to a problem is evidence that no one solution is great or perfect or works for everyone. So over the last 40 or 50 years, the first glaucoma surgery that was proven effective was a trabeculectomy, and unfortunately that's still the most effective tool I have to go to today. If drops aren't satisfactorily controlling pressure, there really is no better guarantee of any other procedure controlling pressure as well as a trabeculectomy that essentially cuts a small hole in the eye under a little flap to allow fluid to sit the natural drain tissue and go through that surgery. There's other varieties of shunting surgeries. In place of the flat silicone tube that goes to a little drainage plate all under the eyelid is another type of surgery. Tubes have their own problems. In fact, every one of these surgeries has their own issues, but a tube may be helpful for lowering pressure, but maybe not as low as what you can get with a trabeculectomy without still needing some drops. And then some newer, this last 15 years or so, there have been many different varieties of minimally invasive glaucoma surgeries, whether little bypass stents, little shunts, devices that are put into a space where there's some other blood vessels and fluid can get out to, with cataract surgery or without cataract surgery, with stretching out the outflow veins or opening up the drain tissue. There's lots of different varieties, but the one issue with the minimally invasive stuff is if they work, they may only work temporarily. It's hard to predict how well it will work until all of a sudden it's not working. So you never can really be given too long a leash or be given too long between appointments. If a minimally invasive surgery is working for you today, we hope it's still working the next time you come back, but we just never really know for sure. And then drops can be helpful in addition to those surgeries. A surgery doesn't guarantee that you'll still need drops, but can be added back if needed later on. I mean, I guess you guys probably all believe when I say that protecting what remaining vision is the mainstay of our treatment. We just don't have any way. Glaucoma is not the same as cataracts, where the cataract gets really bad, it's blocking your vision. Take out the cataract and things are maybe as good or better than they ever have been before, but just isn't the same with glaucoma. If glaucoma does damage, the nerve stays damaged, and there's no surgery that can bring it back. So really protecting the remaining vision is our main target. But if you have limited vision, having good lighting and good contrast are usually the most useful things you find. And then you guys know about magnification and these assistive devices. You probably could tell me more about that than I can tell you, but unfortunately, before getting to that point, having regular follow-up with a doctor who's thinking about and trying to prevent the gradual decline. The natural history of glaucoma is that the longer you live with it, and definitely the more advanced or the more rapid it wants to change, you definitely have a greater risk the older you are with it, especially if you start off relatively young with problems. So I think you believe me if, kind of summarizing that glaucoma causes a permanent optic nerve damage. Early detection is the most important thing we have for preventing vision loss. More commonly is open-angled and closed. Both have their own specific treatments. Most commonly are drops. Kind of second choice would be laser, third choice, third, fourth, fifth, sixth choices would be surgery. And once it's lost, it can't be restored. So we do everything we can to keep what you got as long as you need it. Those are most of my slides. Yeah. Yes.
Question about the testing. First of all, I don't have glaucoma as far as I know, but I do get the pressure test every time I go in. But you were talking about this thing where there's a globe that might have things.
A visual field test.
I'm sorry, I don't even know what I'm asking.
A visual field. So pressure checks, intraocular pressure, IOP checks are just standard with a complete exam.
Right.
If you're not having your pressure checked because you don't want to drop, or it's not really a complete exam without knowing what your pressure is. But if the pressure is normal, between 10 to 20-ish, without medicines, and your nerve looks healthy, we would maybe even specifically mention it. We wouldn't think we need any other tests. If your nerve looks healthy, don't have a history of any specific problem, nerve looks healthy, pressure's normal, you're normal. Like 90% of people, better than 90% of people. A visual field and those further tests are if something seems off, if it doesn't add up, or if there's extra concern. Pressure's high. If you're tense, if you're squeezing or holding your breath, you can make the pressure measurement seem higher than what it actually is when you're relaxed. Things that make your neck vessels stick out, block up the blood flow that's exiting the eye, like playing a trumpet or tuba or really blowing against something hard. Headstands, bending over, that kind of stuff can make pressure temporarily higher. As soon as your head is up and you're relaxed, it can start flowing, normally, and the pressure will measure more normal. Yes, sir.
I'm told that the pen instrument that they use, chest pressure,
Tonopen.
yeah, is often inaccurate, and I had some pressures that were taken by retinologists that was way off.
Yeah.
And I ran into the eye center and they said, what was the instrument? And I told them, he said, oh, we call those random number generators.
What does that mean? Did I say that? Yeah, I've said called it that before too. Like if you're trying to measure pressure with the Tonopen is smaller surface area than the blue light with the yellow drop. They're both trying to measure the inside of the eye's pressure by flattening the cornea. So this picture is probably better to see. So to flatten the cornea, this cornea is about 1/2 millimeter thick in the center. What you're looking through is, on average, maybe slightly more than 1/2 millimeter thick. But you actually have to depress it. You're contacting it without blinking or squeezing. Hopefully keeping your eye open gently. You're flattening it, and it measures how much force it takes to flatten. And the Tonopen is really small, and it can be thrown off by some things. And it requires a bunch of contacts. It has to keep. If this is the little bitty, it's a little bit bigger than a pen. Maybe it's smaller than the end of my pen here, but it has to keep bumping the cornea. And if it gets a good contact, it beeps. If it doesn't get good contact, even though you touched it, it doesn't beep. It takes about 7 or 8 good contacts before it gives you a number. It's trying to average them. And it can just be thrown off by things. Thinner corneas, like the thinner your cornea, the easier it is to flatten, and the lower your pressure will seem to measure, even if it's not actually as low as a thicker cornea. It's a little stiffer. Stiffer corneas, thicker corneas may measure higher than what the intraocular pressure actually is. The only true way to really measure pressure is by having, a little manometer or pressure sensor needle in the eye, and that's invasive. For risk of infection, no one wants unnecessary needles. So we're estimating the pressure by trying to flatten a part of the central cornea. But we know that thin corneas are a risk factor for glaucoma because thin corneas usually are correlated with a little less tough nerves. And if you think of the eyeball as a shell, the front of the shell is the cornea, the back of the shell, the back of the white of the eye, essentially is where the nerve lies, and it's in like a little, like perforate, like the sclera that makes the white of the eye. It's pretty tough. It has all these little perforations that the nerve fibers are passing through to get to the brain. And some nerves just aren't as tough. It's thought to be right there at it's called the cribriform plate. Supports the nerve tissue that's collecting the retina. That's specifically the most sensitive area to blood flow and to pressure damage.
Several years ago, I was being treated for glaucoma, and my ophthalmologist sent me to Atlanta to a glaucoma specialist, and they said, no, you don't have glaucoma. But he still thought I was a glaucoma suspect, but I wasn't taking treatment anymore. But since then, I have developed macular degeneration, and I'm concentrating on that now. But I'm wondering, as far as I know, my ophthalmologist keeps looking at my pressures, but I don't know, are there other tests?
Hopefully your nerve is staying the same.
As long as that optic nerve is healthy.
Yeah, well, if it's healthy, all the better, but it probably isn't healthy or probably isn't totally normal looking. That's what made you a suspect in the first place. If your pressure is normal and the nerve is staying the same, I would feel good about that.
Okay, thank you.
But we do know, just like hairs on our head can thin with age, the nerve tissue can be lost slowly over time. And it depends on how old you are and how much nerve you have. And then, does it look like you're gonna have a shortage of nerve to be concerned about, or does it look like you have plenty of nerve, even if a little bit is lost over time, to still be okay?
Okay, thank you.
The cup to disc ratio, which is described by the amount of nerve tissue as a proportion of the size of the nerve. So say if you have like a, yeah, say like if the end of my cut, of my top here is the optic nerve head, and imagine this is the nerve, but this is the only part you can see. If the nerve was just if this was like the shape of a donut and the hole in the center were small, you've got a lot of nerve tissue. But if it looks like the nerve has thinned, so the hole in the center becomes a lot larger percentage of this part is not growing or shrinking, it's steady. But what fills it can thin with time. And if it looks like there's thinning or loss of tissue, that's more concern. To answer your question, I mean, there's a lot of risk factors with age, but if you have to trade one issue for the other, if they're looking at your macula, they're probably not ignoring your nerve either.
No, okay, but it wouldn't hurt to ask about it.
Yeah, does the nerve look the same today as it looked 5 years ago or 10 years ago? If it's the same as many years ago, that's a good sign.
Okay, thank you.
Yeah. Whichever.
Can glaucoma go away?
Well, not really. I mean, if there's damage to the nerve, it's going to be permanent. But the concern for glaucoma or the problem with the high pressure potentially can improve with time. Like cataract surgery can make your pressure higher for the day of and the day after surgery, but it doesn't mean that you have glaucoma. But people with glaucoma and have some diseased drain tissue, can really get high pressures afterwards, and then the drain tissue is not going to necessarily behave better a year or more later. It's a specific kind of scenario you're thinking of?
I did those purple drops
Yeah, Romanity.
for 10 years, maybe
Yeah.
longer,
Yeah.
and treating for glaucoma. But when they did the surgery to repair the macular hole,
Okay.
they said I had no glaucoma.
Well, your macular hole surgery did not cure your glaucoma, but maybe your eye pressure was better sometime a little bit later. I mean, there's different doctors have different thresholds for wanting to begin treatment. I don't ever want to start a drop if I don't think it's needed, but we can try one for a couple of visits if the pressure's high and wants to be lower for a little while. Sometimes it's a lot easier to start a drop than it is to stop it, because you never really know, one, what the pressure's going to be without the medicine. If it's good with it, you don't know if it's still going to be good without it. And then two, if the medicine's not causing you irritation or allergy or blur or dryness or no specific complaints, maybe sometimes it's easier to continue it than to stop it and find out that you need to restart it. There's lots of different scenarios, but I don't think that the macular hole surgery would have improved the eye pressure probably in any way.
And they said there was, when they did the surgery, they said there was no glaucoma.
Well, your nerve may have looked healthy, and they thought at that point maybe the nerve was healthy enough to have a little higher pressure and not need that medicine, probably. Maybe you didn't need the medicine that long. That'd be the best explanation. Hi.
As we age, how often should, there's a difference between 70-year-olds, 80-year-olds, and 90-year-olds. About how often should we get our eyes checked if you're 70 or if you're 80 or if you're 90?
Yeah, there's not too many folks in here that I wouldn't recommend about once a year.
Says the young doctor.
Can go quickly.
If you're healthy today, you won't be that much different next year without feeling pain or knowing that there's something going on. Unfortunately, there are some people that show up, they thought they were okay a couple years ago and all of a sudden they're not. That's a rare exception. I mean, most people have changes over many years, but you just don't want to take the risk of accumulating many years without knowing something needs to be, treated differently.
So at least once a year.
More or less. I mean, if you have other, I mean, it's not a hard and fast rule, but if you have other more pressing medical issues, it can wait an extra couple of months or 3 months, but then 3 months becomes 3 years, and then it could be a different story. So, I know time goes by faster than it ever has, and before you know it, you probably do. But you should aim for about once a year.
Okay, thank you.
And folks, unfortunately, with more severe disease have to come more frequent.
Well, yes.
But if things are looking about as good as you can get them once a year. Hi.
I'm curious,
Do you inherit this kind of a condition, you know, like family history, or
Yeah.
is there something that brings it on, or what is the reason you
Well,
get?
there's a lot of things that can bring it on, but, it's not a guarantee, you know, that if you had really bad glaucoma, that your children would have the same disease at the same age. They have an increased risk. So on average, it's less than 10% of the less than 10% of the population has glaucoma, but people who have very severe glaucoma have a lot higher risk in their family. You know, an injury, you know, certainly a big risk factor. Injections, if you're getting injections, that can be a risk factor. Steroid use, whether it's for arthritis, or asthma, or Crohn's disease, or, you know, whatever. Steroids, you know, are a risk factor for the drain tissue not working as well. Really, any eye surgery can increase the eye pressure for a while, or make the drain tissue not work as well. Age is probably the biggest risk factor, though. And some people with other nerve disease, neuropathy, you know, have specific optic neuropathy, and, you know, glaucoma is one of those types of optic neuropathy. Yes, sir.
I have macular degeneration, and before I get the shot, typically he withdraws some fluid, so as not to increase the pressure. When I asked around about this, that is extremely rare. Very few retinologists seem to do that.
It is definitely more work and potentially a little bit more risk to take some fluid out. I mean, more commonly there's pushing more volume in your eye, but your eye is, I mean, kind of like a tire. Like, you need it to be filled, you don't want it flat, but it doesn't expand, you know, it just gets tighter. So the shot that you're getting once a month, or every 6 to 8 weeks, or, you know, if you're lucky, longer, it's gonna be like, you know, 1/10 to 1/15 of a milliliter. You know, the eye itself, you know, is many milliliters, but that fraction is a difference of making some pressures higher. I mean, they can check the pressure before and after the shot, or
Before
check it
always,
10, 15
never
minutes
after.
after. Yeah, if they're taking some fluid out, I guess maybe they figure they don't have to check you after, because they're maybe taking out as much as they put in, but, I do know some retina doctors that check pressure after, and specifically then if it's high, then I'm hearing about it and seeing the patient the next couple of days, or something like that. The better controlled your pressure is before the shot, the better control is gonna be after the shot. You know, there's no part of the shot that's gonna make your pressure better, unless they take a little fluid out.
Is there anything promising in stem cell research?
I wish there was. I mean, I think a lot of smart people who aren't seeing patients as, you know, every day like I am, are doing research and trying to find that. But I think specifically the hardest part of stem cells is to get the connections, you know, to the brain in the right spot. Like, you can grow a new nerve, but if that nerve isn't connected to the brain the way the brain developed, you know, when we were children, it's just not useful. There's not any useful nerve repair for the eye or for the brain that I'm aware of right now.
Where is most of the research being done in the United States?
I mean, academic centers, I think closest to here is Duke, Vanderbilt. I don't think Vanderbilt does quite as much ophthalmology research as Duke. Mayo,
Stem cells.
Wills in Philadelphia. Places that had, like, you know, some of the most difficult to get into training programs are the most prestigious for the research. Stanford, Baskin Palmer in Miami. I mean, the United States is lucky to have a lot of, you know, really top-notch research institutions. I personally don't enjoy research that much. I like patient care a lot more, so I don't, you know, have the ability to tell you what, you know, hasn't been published yet, you know, what people are working on. In some of our meetings, you know, there's always stuff that sounds promising, but then, you know, is it really
It doesn't
ever
pan out
going-
down the road.
like, how much of a difference and how practical is it to deliver to people who need it? It's a difference. I think much more likely is gonna be some kind of camera. You know, we've got good cameras now that fit, you know, in your pocket, or in glasses, that would be then connected to the brain, you know, for some kind of processing. That's, you know, that's out there pretty far too.
The Chinese are doing something
Yeah.
along that line.
Yeah.
But, you know, who wants a Chinese chip in their brain?
Yeah, the chance of getting infected, is significant. And, when talking about glaucoma tubes, the tube is meant to be covered under the body's tissue, and it can be covered for a long time until it's not. But anything, and it's a small silicone tube that's supposed to be as, compatible with the tissues as possible, but even something that's rounded or flat and soft, still, if it's not your body's own tissue, sometimes it just doesn't, stay where it needs to be for as long. So any kind of wires or implanted, microchip or camera, I mean, it's difficult to keep where it needs to be healthy without, concerns of infection and pain, that kind of stuff. Yeah.
It sounds like one should have regular pressure checks. Is this important is this important at a younger age as well?
Well,
Like someone that's 30 or?
yeah, someone who's younger has a lot more nerve tissue than someone who's older on average. So potentially they could lose some and still be okay, like hairs on their head. If the nerve looks healthy in a young age and the pressure's normal, that someone may not have to be checked every year, but every couple of years. But, as blood vessels are not as healthy with older age, blood pressure, restrictions, whether it's from calcium buildup or cholesterol or whatever, when the blood vessels aren't as healthy and the nerve fibers not as plentiful, that's when really that balance of eye pressure can make a bigger difference. So it just becomes more important.
I was just thinking of someone with Crohn's disease that might be about 40, so.
Yeah, they may be on steroids and they may have, inflammation, not just in their guts, but
Yeah,
in other parts of their body, be an extra risk factor.
so it'd be advisable to make sure they had
Yeah, even if
pressure tested.
yeah, it may not be the pressure as much to worry about as just, other eye health. So that would just be one component of a complete eye exam, would be helpful, probably at least every few years, even without symptoms, in a 40-year-old. Yeah.
Can you mention, lifestyle or behavior or food? Any other health
Yeah.
issues that a person with glaucoma should be aware of?
Yeah, so things that are heart healthy, for your blood pressure and for your heart in the blood vessels are generally healthy for things that are as healthy for your eye as possible. Smoking's a risk factor for everything, definitely including the small blood vessels that feed the nerve. Hydration helps. Sleeping with your head elevated a bit. I see some people who don't have high pressures in the office, but their nerve doesn't look very healthy, and almost the only way you can explain it is, and often they say yes, that they sleep on that same side down, pillow pushing on their eye, or they sleep like this with their knuckle pushing on their eye, and that just isn't getting as good a blood flow when the head is flat or down or getting pressed on. The pillow sometimes too, while it's soft, it applies enough pressure to the eyelid that isn't helpful for small blood vessels. So you have to go up your neck and then branch off 5 or 6 times before they get to the eye. And those vessels in your eye are finer than hair. So we're not talking about vessels that have any kind of size that you can feel a pulse in or see, except with a microscope. They're fine, really fine. So did that answer the question? I'm gonna give you some things to think about. Heart healthy, blood pressure, hydration, head elevation. Those are the most useful things. There's just unfortunately no vitamin that's helpful really for glaucoma. The macula, vitamins are different for that. But really, it's a blood flow and nerve condition. So, yes, sir.
I have a CPAP machine and it presses against
Yeah.
the side of my nose.
Yeah.
My nose, sometimes it pushes against the eye a little bit. Is that a good thing or a bad thing?
It's not helpful for your perfusion of the retina and of the nerve if your eye's getting pressed on. So you definitely want to make sure the fit is adjusted as well as it can be, that it's down, pressing only on bone.
Yeah.
You really don't want it pushing on your eyelid above the orbital, the bottom orbital, floor here. I know that those aren't real comfortable. You maybe just get used to it, even if it's not fitting well, you get used to it. But you should try to get the fit adjusted so it's not pushing on your eyelids.
Well, I know that I was used to wearing a sleep mask. and it's soft and it's cuddly and everything. But I noticed it is putting pressure on this eye that he did surgery on. So I quit. I mean, I didn't want to risk.
Like one of the satin, like.
Yeah, it's satin, and it's very soft, just to keep any light out.
Yeah.
But I quit wearing it because I was scared
Yeah.
any kind of, and it's even domed, you know, where it keeps it away. But I could still feel it against my eyelid, and so I stopped. I stopped wearing it.
Yeah, I don't think that sounds as risky as sleeping, you know, with the
Right.
pressing into the pillow. But yeah, if anything is touching your eyelid and you can open your eye, you know, then it could potentially scratch the
Right.
surface of the eye. That's not helpful.
Right,
So, you know, like after cataract surgery, we send you home with a shield,
right,
but we don't want you putting any kind of gauze or,
right.
you know, like we don't want you putting a washcloth or anything like that, tissue behind the shield because we want your eye to get
Right.
dark.
I try to do what I'm told. I don't always.
Yeah.
As you know, I've had tube shunts in both eyes, and both of them have come out.
Eroded, yeah.
What is the failure percentage of the tube shunt surgeries?
Yeah, I think it depends where it's done. One, how they placed it and how flat it fits to your eye. And then if any anti-scarring medicine was used when it was placed. And there's risk factors, but the general answer to your question is, you know, probably less than 20% over 10 years. I mean, most stay covered, thankfully, but occasionally if the surface is just prone to breaking down, whether your eyelids are tight or your eye's extra dry, or maybe the tube stuck up a little bit higher. There's so many variables. It's my least favorite surgery to do because there's so many variables. You can't control some things.
So there's 80% success rate in 10 years.
Yeah, I would say that's kind of a rough.
You're fine.
Yes. I think so. One of the research things I did as a resident was specifically looking at tube exposures. And for sure, the guy I trained with that used an anti-scarring medicine had a little bit higher rate of exposure than people who don't use an anti-scarring medicine. His pressures were lower. The eye didn't scar as much, but it broke down more frequently. So it was really a balance.
So what would an anti-scarring medication be?
Mitomycin. Mitomycin is the one we use with trabeculectomies and can be used with tubes.
Oh, I have that too.
Yeah.
That's,
Mitomycin is an anti-scarring medicine. It specifically was used for colon cancer. They found that it kept the white of the eye from scarring as much. So drainage, surgery and drainage areas drained better when that was used. But it more commonly can lead to the tissue breaking down. Blood vessels and scar tissue are helpful for covering things and closing up things, but not so helpful for glaucoma surgery. Then you want the scarring after the tube is removed because you want to keep everything else covered up.
so basically, the silicone tube was what was poking out through
Yeah.
cornea.
Not the cornea, the surface of your eyes, the conjunctiva. Yeah, the tube comes, yeah, what comes under the surface tissue and it goes through the peripheral cornea to be in this space. But it wears out here, under your eye.
Thank you.
Yeah. You guys have been a good audience. Any other questions? Oh, okay. Well, one more. Yes, sir. You didn't ask a question.
In passing, you mentioned cataract surgery.
Yeah, my favorite surgery.
Are there any new developments or things that we should be aware of?
Well, the lens implant options continue to evolve, but the surgery itself is mostly the same. I mean, we get new machines that make it easier or safer or faster, but as the patient undergoing the cataract surgery, it's going to seem about the same to you, except for the lens implant option. And then whether your eye's healthy enough to consider all options or not, the lens implants have evolved over some time. For just being better, better fits, more compatible, less likely to cause you trouble, but also give you better vision. Maybe not to need glasses as much or to see better lighting conditions and different distances, things like that. I think cataract surgery, because it's like the most common surgery performed in the United States, is an area that continues to be improved, thankfully. It's gotten to the point now where we do cataracts that aren't that bad before they're that bad, because it's, very high chance of success and satisfaction. But unfortunately, glaucoma is one of those reasons that you might not have as much satisfaction with your cataract surgery if there's other problems. If there are other problems, cataract surgery is very happy with most people.
You mentioned wind instruments can increase pressure.
Yeah.
If you don't have glaucoma,
Yeah.
should you avoid wind instruments? And
I
is
like
anybody interested in a spare trumpet?
Unless you're playing like, multiple hours a day, or, unless your nerve is really damaged, it's probably not an issue. Probably not an issue.
We can make you an appointment if you'd like us to see you.
We can take your pressure before, during, and after.
Well, I mostly stick to keyboards.
That's safe. Yeah, thank you guys, you're a great audience.